the next slide.
Yeah, you don't want to hold it the whole time.
Whatever works. Thank you. All right. Okay, cool. Thanks. All right. So first off, I'm Robert Marks, pain management physician, and this is Dr. Sauman, Rafii, also a pain management physician. He joined our practice diagnostic pain center, I guess 3 months ago. Yeah, that's. So I went to undergrad at UT Austin, did UT medical branch for med school down in Galveston. A year of general surgery for internship up at Stony Brook in Long Island. Moved to Lubbock as a categorical general surgery resident and planned on doing vascular surgery. About a year and a half into it, I realized as my daughter was born that I really kind of, what I loved about vascular surgery was in the interventional radiology suite. So I basically talked to the guys about how I could live kind of the life of the interventional radiologist and actually know my family. And he's like, dude, one of the top fellowships in pain management is right here. I was like, really? Like, never heard of that. So I looked into pain management and ultimately transferred to the anesthesia department and did the fellowship at Tech and love it. It's been a lot of fun. So my wife and I met in 2nd grade. We moved here in, I guess, 2012. And that was that. And Dr. Rafii, you want to tell a little bit about yourself?
Yeah, absolutely. So I grew up in Northeast Ohio. Pretty much spent my whole life there, undergrad, med school. And internship, and then I moved out of Ohio, went to New York City and did my my anesthesia residency at the New York University. Stayed there for my pain management fellowship as well. And then I don't know how it happened exactly. I can get into details if you want to, but I ended up in Iowa. And practiced out there for about 2.5 years, and then decided I needed a change. So warmer weather, better food, more things to do. So that's what brought me to Austin.
So Dr. Malpani, when he first told us about the lecture, he sent us some information. I understand there was, as you guys all know, there's so much going on with opioids these days, and part of really, I think that my understanding at least was a big part of this was kind of a matter of, hey, like, talk about opioids with us. You know, there's kind of obviously pain management kind of has a different perspective, and my initial understanding largely came down to how primary care would kind of look at sort of in terms of prescribing opioids. And I'll get into it. First off, before I jump into this, as I say, you know, this is the lecture you weren't expecting to witness. Not the classic pain management lecture, I suppose. I'll preface this with, I'm extremely controversial. This was me in front of the Capitol. Some of you guys might have seen me on KView back in, this was in like March, talking about why we need to actually at least let the legislature hear some of the debates and the discussions regarding the extension of medicinal cannabis, which I know is obviously a controversial topic in and of itself. As I said, I'm no stranger to controversy. And I'm actually going to touch a little bit upon that. This was actually my Grand Rounds topic. I never thought that I'd become an advocate of it until I really learned as much as I did about it. But this lecture is kind of maybe sort of similarly controversial because my perspective on this, prescribing opioids for non-cancer patients. Honestly, I started putting this lecture together, and as I was doing it, I really had a major ethical concern about even recommending the idea of just saying, hey, we've got chronic pain patients, let's put them on opioids. Sure, there might be a safe way to do it, and under some circumstances, I won't deny it. You know, there might be cases where somebody truly, there's absolutely nothing else to do. There may be some circumstances, but the bottom line is, as we all know, there's a true opioid epidemic that is taking place in our country. Austin is probably one of the most notorious pill cities that you're going to run into. Everybody in the city who goes to pain management somehow manages to be on opioids. And I know that you guys, everybody who sent patients to us, because I know approximately between 98 and 99% of our patients that are on opioids were on opioids when they first came to us. And the referrals frequently are, hey, their pain doctor moved, we need you to take over their pain medicine. And the unique thing about it is we get so many patients that come in that aren't on opioids, and we don't put them on opioids, and they get better, and they're the ones that tend to leave the Yelp reviews, I suppose. So as you guys see here, so 91 Americans die every day from an opioid overdose. That's according to CDC.gov. That's data available today. If you go to the website. The simple answer in terms of prescribing opioids for non-cancer patients in general is don't. If you really have to, sure, but try not to. There's a few different, I'll actually go back one second. So there's a few different perspectives. You guys know there's a lot of pressure from patients to give them pain medicine. I have no doubt that you guys have all sorts of people when they come in, they hurt their back and they ask you guys, hey, just give me some Vicodin, and whatever. Everybody asks. I get the same thing. And in pain management, we actually get it in very unique and frankly sometimes extremely scary ways. I'm not the only member of our staff that does in fact carry a knife in my white coat. Extortion is one of the ways that I've experienced this. Patient that we fired for doctor shopping, she called our office and flat out told my staff, if Dr. Marks doesn't refill my medicine, I'm going to write a bad review about him on Facebook. And my response to my staff at the time, it incorporated a few four-letter words, but ultimately it was also a matter of be sure to document that in their chart and let them know it'll be documented in their chart. So if they do, we'll be sure to not only let Facebook know, but also the authorities for the extortion. Also, one of the really scary new things that it popped up with 2 patients within about a month period. I have to imagine that they were probably friends with each other, but this is really scary. Social media has a very scary impact for healthcare, and you guys know this, but when it comes to opioids, it's a really big issue because you can barely even reply to it. This sounds kind of weird to say, but I mean, of 37 Yelp reviews, I have 1 review that's a 1-star review, and it's somebody that came in and told me that she got 100 methadone per month and threw away 90 of them and wanted me to continue giving her 100 methadone per month. And as I said to her, look, that's fantastic if you really throw away 90 of them, but if you're going to do that, like, why don't you just keep them and not go in every month? And she requested that I go ahead and just get the medical records, and I said, hey, I'll get the medical records. If it turns out this is really true, maybe I'll give you 10 a month, and but that's it. I'm like, I'm not going to do this. Like, that's not appropriate. She said, okay, well, go ahead, send off the urine drug test, get the records. So we got the records. We sent off the urine drug test. That's the one that says that I send off for urine drug test and shouldn't have. Thanks. So anyway, but this was the epidemic thing that scares me. Somebody actually went, and this was the Yelp review. Wow, all these 5-star reviews. I'm going to go see him on Thursday to see what this is all about. I'll update after seeing him. Patient comes in, one of the shadiest people I've ever met in my life. You look on that Texas PNP database, and it's like gobloads of ERs, other pain doctors giving them pain medicine. And the first thing she says, she's, oh yeah, no, I saw your reviews on Yelp. I left a review, in fact. And I already knew this going into the room, but the extent of how delicate you have to be as a pain management physician, and also bringing that to light to you guys, because as I always tell people, you're not always going to get positive feedback about pain management doctors. I look at it almost as kind of largely a political thing. With the patients, you have to blame everything on the Texas Medical Board and blame it on something. And of course, I believe that you weren't really doing cocaine. Of course, that drug test isn't really legitimate about heroin and coke. It's no question that's. But I have to go by that objective finding. I'm sorry. It's like, I believe you, but can't do it. So anyway, next thing that we get sometime are threats, and for the sake of making this a little bit less cumbersome, Dr. Rafii is going to read the patient part. I'll be reading the other part. So the discussion really did go this way. I can't refill your morphine. You put a month's supply for both me. You got a month's supply for both me and another doctor, and there was 0 in your drug test.
But I'm going through withdrawals. That's dangerous. You need to give me more.
Nothing's going to happen to you. It wasn't even in your system.
I hope nothing happens to you on the way to the parking lot.
That's not a threat.
Maybe.
You better get out of my office before the police arrive. My staff have already called them. That's actually happened more than once, by the way. People, there really are situations that I've truly been very scared in our office. So every one of my office staff already has carte blanche from me. I've told them if somebody comes in, our receptionist, even if it's a brand new receptionist, I've told them if you ever feel threatened in any way, shape, or form, although I always tell all of our staff, be as nice as possible. It's almost that patient is always right situation, but I've told my staff, if you ever feel threatened, tell them to get the heck out of our office immediately. I was like, don't hesitate to call the police, bring me up, I don't care. I was like, I'm not gonna put up with that. So just to make you guys aware though, so some of the things that you guys realize kind of come from us. So you also get some of these unique creative lies. This was a middle of the night weekend call that took place a few years back. And actually, I won't lie, it wasn't Tylenol before, it was Vicodin before it was a Schedule II drug. Call center calls. I have a patient of yours who said they lost it was Vicodin and need some to get to next week. It wasn't actually a patient of mine. And that's a unique thing. Notice they chose a Schedule III drug. You as a patient, you could theoretically call 60 different doctors in town. They could call you guys. And if it's at 2 in the morning and it's a drug that you're able to phone in and you think maybe this is a legitimate patient, I can document this in the morning, just give me the phone number and your date of birth and I'll phone in for a couple of days supply for you. It's a very unique little trick. Just kind of part of the disturbing aspects. So anyway, I look at healthcare, frankly, the same way I look at business. I have a solo practice. Well, actually, it's not solo anymore. I'm sorry. Had a solo practice. But anyway, but I look at everything in terms of a balance between intent and competence. And you guys will see, actually, I have a couple of slides coming up soon for all you Silicon Valley watchers, which is the greatest show on earth. If you're not, you should watch it. It almost reminded me of the conjoining triangles of success. Anyway, but when you look at the balance between these, first you always have to ask, why did we go into medicine? I went into medicine for the same reason that I assume most of you guys went into medicine. I genuinely wanted to help people. And maybe it sounds cheesy, maybe it's, I grew up, my dad's an orthopedic spine surgeon up in Dallas, and he brought me to the hospital when I was a kid to go around on his patients. I'd always hear the greatest things about how much he helped them, and he always taught me about you respect everybody, respect the nursing staff, respect the custodians. Everybody deserves equal respect, and my whole mantra in life ultimately became a matter of, to be successful is to be respected. It's not to be wealthy, it's to be respected. Of course, everybody would certainly love for the ladder to follow, don't get me wrong, but be respected and do things the right way. So the idea behind Diagnostic Pain Center is exactly that, diagnostic. Pain management is one of, let's not kid ourselves, it's one of the shadiest fields in medicine. And the reason for that isn't to say that everybody that does pain management is bad. It's the fact that it has the potential to be, because effectively it's a 100% subjective field of medicine. And Dr. Rafii and I try to see the objective side as best possible, which is the reason that the slogan effectively is diagnose the pain, treat the problem. But I wanted to go into practice when I first started out, where I wasn't gonna have somebody breathing down my neck saying, hey, you know what, like this guy could get a series of 3 epidural steroid injections, and this guy could get put on hydrocodone, and we could check their urine every single month for patient safety rather than less frequently, and make money off of that. And there are all sorts of other ways that people could ultimately end up capitalizing on the subjectivity of medicine that cannot actually be proven to be good or bad, but ultimately does in fact line people's pocketbooks, and I didn't want to be a part of that. The way I see pain management, and largely too, I've interviewed over 50 different doctors, so Dr. Rafii turned out to be the perfect complement to the practice. We see this as a specialty that should ultimately be a liaison between primary care providers and specialists. We work people up. We get a solid history, physical exam, 45 minutes for every new patient, and answer their questions. I'm always running late. One of the biggest complaints is, Mark's is an hour behind at the end of clinic. One of the biggest complaints from my wife is, why weren't you home for dinner? But she doesn't complain anymore because she knows that I'm not gonna be home. That's why I try to end clinic at 4 and get home at 5:30 or 6. But anyway, the bottom line about it though is getting an appropriate workup and figuring out what is the actual diagnosis. How can you really actually treat that issue? So that's intent. The intent to actually do the right thing. Then there's the competence side. And largely that frankly comes down to the business model. How are you actually running a practice? Wellmed, I think, is actually a very, very good example because quite frankly, and I say this sincerely, with the exception of Wellmed, I've actually always kind of abhorred the HMO concept. I think Wellmed genuinely is, you guys do it right. I think that your patients actually get very good quality care. I have an HMO insurance plan, and it's horrible. $7,000 per family member deductible. My wife had to get like a workup for something recently, and like I had to submit the order for it because if we went to the ER, it wasn't going to be in network, and it would have cost us thousands of dollars. So, but I think you guys do very well. But the business model ultimately plays into the degree of competence. And part of that also plays into the patient value, and this is where it's a little bit scary, because if you get an extremely competent practice that says, hey, we can really capitalize on this, and how can we bring in every single dollar? Again, when you have a subjective field of medicine, that can play into additional drug tests, additional, the patients that are put on opioids become a recurring revenue stream. The standard of care that's effectively, although legally you can get a Schedule II drug for 3 months at a time, the standard of care has effectively become that you see them every single month to be able to document exactly why they're on it. But the fact is, there's a conflict of interest there because of the fact that you're also getting paid for those office visits. And then the patient needs to pay money out of their pocket for those office visits. So, but people look at what the overall value is, and then of course you balance it out with how much the overhead is. I try to focus our practice on being as efficient as possible to minimize the overhead. So this is where I look at the balance of intent and competence. And this is how it plays into opioids. You look at, if you have good intent and good competence, that's telling a patient, hey, you know what, it's not a good idea to start opioids. Pain will go away with an NSAID, give it a little bit of time. And that's how I wish people would generally start out with everything. But then there's good intent and bad competence. And again, I'm not trying to insult anybody here. I mean, everybody does this sometimes. This is just sort of an broad generalization. But starting opioids because it's the easy thing to do. And I can tell you guys, and I'm sure you guys have had the same discussions. You can satisfy a patient by saying, yeah, okay, I'll give you a prescription for here's 30 hydrocodone. They're out the door, they're smiling, they're happy, you're moving on with your day. You tell them no, you have to explain why, and it's going to take you a lot longer. But it's patient satisfaction. Patient asks for opioids. You get that. Then there's bad intent and good competence. That's probably the most dangerous. That's the guys that are starting opioids to increase a revenue stream. That's the real cunning businessmen. That's if you keep the patient satisfied, they'll keep coming back. It's Starbucks provides an addictive product, whereas Krispy Kreme doesn't, and it's why Starbucks runs circles over Krispy Kreme, even though they used to say when the Krispy Kreme IPO came out that it was going to be the next Starbucks. It's not, because it's not addictive. Increases revenue, grows practices. The more money that they bring in, the more money they're able to then spend on advertising. I can't compete with a $250,000 monthly advertising budget, so the other practices that are doing this end up growing exponentially. And then of course there's the other bad side to this, although I don't think it's as bad as good competence and bad intent, which is good or bad intent but bad competence. Overprescribing opioids without the thought of consequence causes overdoses. Now I'm sure a lot of you guys are probably looking at this and thinking, yeah, this isn't really applicable to me. But as primary care providers, ask yourself, when you look at the two core values that tend to have inversely proportional outcomes in terms of the patient satisfaction is inversely proportional to patient care. Notice the words that I underlined on here. Now let's change it up to something more applicable to you guys. Telling a patient it's not a good idea to start antibiotics because the symptoms will go away with an NSAID, give it time. Or the good intent, bad competence. Starting antibiotics because it's the easy thing to do. If somebody just calls, they got a little bit of a headache, you know what, let me give you a Z-Pack. You know, patient asked for it, because I'm sure you guys get calls all the time. Hey, can you give me a Z-Pack? I think I have a sinus infection. And you know there are plenty of doctors that do that. And then of course there's the bad intent with good competence. Everybody gets antibiotics as soon as they ask for it. It keeps them coming back because God forbid the patient is upset that they don't get their antibiotics, so they decide to go find another doctor. And I'm sure there are plenty of primary care providers that need to deal with that. So again, increases revenue, grows practices. And then of course, bad intent, bad competence. Overprescribing antibiotics without thought of consequence causes antibiotic resistance. So we're not that much different, you and I. So conflicts of interest when it comes to opioids. Monthly office visits, as I already kind of touched upon, toxicology screening. One thing that, although I do have to spend a few dollars for every point of care urine drug test that I do, yes, Vishal's heard me complain about the fact that Wellmed won't pay me back for those, even though everybody else does. But at the same time, despite the fact that I'd love to be able to get paid back for my, whatever the heck that code is, 80305 or something like that, yeah, it's kind of a semi-issue. But at the same time, I actually respect the fact that you guys don't, because if you look at toxicology screening and the kind of impact that that's had, you can see how practices can actually build up based on that. January 2015, Medicare announces a significant cut for in-office urine toxicology. You see practices throughout the state and throughout the country, shutting down clinics left and right, borderline bankruptcy, bailouts, et cetera, et cetera. It happens because they're built on sand, because they're putting people on opioids. And that's not necessarily an issue with the individual doctors, it's an issue with the fact that sometimes it's extremely difficult when you can bring in the revenue that's 5 to 6 times what that's for the complex type of thing, not these point of care cups I'm talking about, by the way. I don't have the fancy stuff in my office. But that's those fancy drug tests they would pay multiples of what an office visit would pay. So there was a huge conflict of interest there. Big Pharma, I'd say pretty much every week we've got one of the companies that's bringing us lunch, whether it's Xtamps, ER, or Zoos, or Zohydro, whatever they are. And honestly, the funny thing is you'll notice I have a little bit blunt about matters. They know that I really don't particularly respect the pharmaceutical industry very much, but at the same time, I respect them as individuals. I just think that it's a little bit dangerous. But the concept of abuse deterrent. I genuinely do not believe that of the 91 people dying every day in our country of opioid overdoses, that the vast majority of those are because they're trying to inject the medication. I think the bigger issue is the fact that people are prescribing them, and that gives a very unique guise of safety. You guys know within the past week, Opana extended release was actually pulled from the market because their abuse deterrent wasn't actually working very well, and the people that were actually trying to inject it ended up with blood clots. They also have their unique savings cards. So they'll knock out how much your copay is until you've met your deductible. But of course, that helps you to meet your deductible. So once you've met your deductible, these guys are making a lot of money off of those prescriptions. Those savings cards aren't for the patients. It's so that the patients are, hey, I need this drug. This is what I take. This is what I'm hooked on. That's scary. And then I will get into this in a few minutes. Funding anti-cannabis campaigns. You'll see why I actually feel so strongly about this shortly. I testified to the legislature about this. And then finally, patient satisfaction incentives, as I kind of touched upon earlier. But it's not just a matter of online reviews, which make a difference to me. It's the hospital system. It's, when I was doing my fellowship at Texas Tech, everybody said, hey, you know what, we should ask our patients to give us a 5 because we want to be in the 98th percentile. But the problem about that is you're not going to get a 5 when you have somebody that comes in and says, hey, I want more pain medicine. You say it's really not indicated. I'm sorry. You're not going to get a 5. And if you're going to have to strive to be able to get perfect scores, while simultaneously the best patient care goes against what the patient necessarily wants, that's not necessarily the best benchmark. Now, with that said, there were a couple things that you guys had sort of kind of inquired about, and this is just one slide for each of these things, but just a little bit of perspective. Not being as anti-opioid here. There were some questions about what morphine equivalents are, and basically just a very, very simple way for everybody to be able to think about it. And this is how I talk to my patients about it. It's effectively looking at the same concept as a dollar exchange, a currency exchange. A dollar is worth X number of euros, is worth X number of yen, and when you compare it like that, you're doing the same thing when you say morphine, 10 milligrams of morphine equals 10 milligrams of hydrocodone equals equals like 7.5 milligrams of oxycodone equals 15 milligrams of morphine equals 5 milligrams of Opana, et cetera, et cetera. And if you go to, we usually use Global RPH. They have some pretty good opioid calculators. If you guys are ever looking to try to convert something, this is basically, the numbers on here are at least fairly legitimate. I will say it was sort of a Google search for just a chart that actually had not too much information, but a little bit. But just to be able to compare it, that's what all this morphine equivalent business is about. The next thing is there was some discussion about weaning opioids. This is generally our approach in our practice, at least, which is if you usually have somebody who's on a long-acting and a short-acting drug. And my whole philosophy about it is if you have a patient that's motivated to be able to get off opioids, and a lot of our patients are ultimately, You get them to try to whittle down all of the short-acting drug, because that's going to be in like smaller little blocks. And then as soon as you get all of that short-acting drug, you lower the long-acting drug basically by the same number of milliequivalents, or morphine equivalents, excuse me, as the short-acting drug, and you resume that short-acting drug. So that becomes, as I put it on there, budget neutral, using that sort of dollar exchange thing. So, and then you have them titrate down on that short-acting again. So an example of this is if somebody's on a 25 microgram patch, I generally, of fentanyl, I'll generally look at 12 micrograms of fentanyl being approximately the equivalent of like five Norco 10s. So I might tell somebody, all right, here's what we're gonna do. You're on Norco 5 times a day, and you're on a 25 microgram patch. Wean yourself off of all of that Norco, and then when they come back the following month and they've weaned themselves off the Norco, I bring it down to a 12 microgram patch and resume 5 Norcos a day, but it's budget neutral. It's the same amount of equivalent, and then they can titrate down on the short-acting drug again, and then get rid of the 12 microgram patch, resume all of the Norco, and then they wean themselves off again. It's a very simple, straightforward way to be able to do it. It's not always the best way, it depends on circumstance, but that's generally sort of how I think about it, at least. I don't know if you have anything to add to that one way or another.
No, I think there's no right way to do it, right? There's no textbook way to wean a patient off. I mean, you could do it this way. You could either, if they are on a long-acting and a short-acting, you could reduce one, get them off the one, then move on to the other one. Generally, a good baseline rule of thumb is like 10 to 25% reduction per week, right? It's pretty, but ultimately there's no right way to do it.
And also bear in mind, opioid withdrawal is not actually a dangerous withdrawal. It's uncomfortable, but it's not dangerous. And for what it's worth, that also sometimes plays into the heroin epidemic, because you see practices that will terminate an opioid patient because they fail a drug test, and you'll see patients that are on ridiculously high doses of opioids, and all of a sudden they come back and somebody tries to wean them down. The patient can't really handle that very well. Patient ends up taking somebody else's pain medicine, or they overtake their pain medicine, and they get fired from the pain practice. Nobody else is going to take over that medicine. What do the patients do? They turn to heroin. So anyway, I don't actually generally see that very often, hardly at all, but you certainly read about that. The next thing that I just wanted to kind of touch upon, and this is also controversial, but I testified before the Texas legislature about this, and I feel very strongly about this, is cannabis. We can't legally talk about cannabis. Well, actually, we can legally talk about it at least, but we can't make the recommendations for people to use cannabis. And I kind of somehow put myself in a position over this past legislative session as kind of the doctor that talks about it now publicly. And my hope, for what it's worth, and after this, maybe some of you guys would be willing to join me on this, because I do think that some laws need to be changed. Cannabis is unique. If you look at studies, and first off, an article in JAMA, this is from 2014, retrospective analysis, that's all you're going to find is retrospective studies. States with medical cannabis laws had a 24.8% lower mean annual opioid overdose mortality rate compared with states that did not have such laws. That's a lot. In the state of Texas, we've got approximately, it's a little bit over 8% of the population, 91 opioid overdose deaths per day. That brings it to about 7.95 deaths per day in the state of Texas on average, based on that statistic. This could theoretically save 2 lives per day in Texas. And even if you want to say that's bogus, even if it's half of that, fine. So we save 1 life per day in Texas. It's still pretty good. Retrospective studies also show less opioid prescribing. If you look, I mean, even our own government's websites are starting to show data that shows improvement in terms of how many opioids are prescribed, how many ER visits there are for overdoses of opioids. There's a lot of data that it shows. And I'm not standing here saying cannabis should be recreational. I'm not. I do feel it should be medicinal. But at the same time, when people are talking about it, I think a lot of people are comparing it to alcohol and tobacco and saying, hey, you know what, it's really not such a great drug. The reality of it is I'm comparing it to opioids, because we see what opioids are doing to society right now. And clearly, when you look at the retrospective analysis, people are in fact using this instead of. Part of the brain that controls breathing, the brainstem, doesn't have receptors to cannabinoids. This is the reason ultimately that there have not ever been documented overdoses of of cannabis causing death. It just doesn't affect breathing. The prospective study is very difficult in our country due to federal limitations, lack of funding. No pharmaceutical company is going to fund a cannabis study because there's no money in it. Why would a pharmaceutical company want something that somebody could actually grow? And of course, the federal limitations aren't going to allow it to happen. And drug companies won't profit. There was INSYS donated $500,000 in 2016 to fight against it in New Mexico, while they were simultaneously obtaining FDA licensing for their own synthetic THC product, Syndros. And the article that I actually read, I only have I think 2 slides left, by the way.
Okay.
The article that I had read about this actually was quite unique in the sense that they had actually said that it's dangerous that people wouldn't want a synthetic cannabinoid and were instead wanting to go with something that's grown that's just grown in people's gardens, which I think is interesting because that vantage point kind of goes along with the whole concept of organic that people seem to kind of really prefer these days. I'd rather have, I don't really want synthetic meat personally. I don't know, it's just an issue to me. And then this was actually just some calculations that ultimately, when the Texas House Health Committee actually did pass this, which was the furthest this legislation had ever actually gone in the state of Texas this past session, they intentionally waited until 5 p.m. on the last Friday before the deadline to actually pass things through the House to even schedule the vote. It passed the Health Committee. They had enough members of the House of Representatives who had already signed on to the bill that it would have passed the House of Representatives, but it didn't make it through the Calendars Committee in time to actually be heard by the House, so therefore the bill was de facto dead in session this session. This was something that, because I spoke with a number of the legislators during that time frame, and I was talking to members of the House, the Calendars Committee, and asking them about it. I said, and they consistently said, well, yeah, but you know what, 2 years from now, you can count on the fact that it's going to pass then. And so I actually brought this to them, and ultimately, when you look at the statistics that I pulled up, and again, you don't have to believe all statistics. I recognize nothing's perfect here, but ultimately, just based on those statistics, you effectively would be saving 1,434 Texans saved by passing it in 2017 versus 2019. So there's a lot of potential that drug can ultimately have. And again, the reason that I'm really talking so much about it is because of the fact that I'm looking to try to curb the opioid epidemic, really and truly. But anyway, that's pretty much the probably the most controversial lecture I've ever given. I hope it was at least somewhat either entertaining or informational for you guys. But I'd love to open it up for discussion. That was ultimately the goal, was for people to talk about these things.
Well, I would say that I'm from Washington, and cannabis is legal, and I have seen the difference on a professional level there. So.
What are their feelings about it? Do they tend to be pro? I mean, do they see more good than bad?
I think pain. Well, I hate to say this to you, but pain management as a field is kind of lessened.
That's good.
Yeah, I mean,
I don't care. I'm happy about that.
Lessened, and yeah, they're pro. Generally speaking, primary care providers that I know on a personal and professional level are pro.
Yeah.
Yeah.
I will say I've spoken, because I've always been outspoken about this. I've spoken to probably a couple hundred docs over the past few years about cannabis, and very consistently they're pro. If any of you guys are comfortable enough with being willing to actually talk publicly, or just even willing to talk to patients about it, I do theorize, I really do, that we are in general scared to talk about it because of the board. And because we're scared to talk about it, patients don't feel that their doctors think it's a good idea, and therefore patients don't talk to legislators, and therefore legislators who want to get reelected don't feel that their constituents want it. And because they don't feel their constituents want it, it doesn't get voted, and nothing ever changes. I personally know I'm putting a big target on my back even talking about it. Sir?
Yeah, what's the medical board say about it if it shows up in a drug test or whatever, and then you're going to prescribe them meds? Is that an issue with the medical board? Or?
It is. According to their official stance, it's an issue. And what's ironic, actually, is I've actually spoken specifically with Bruce Levy, one of the I should have said that out loud, but one of the former presidents of the medical board, though. I'm good friends with his daughter and him and his wife, and actually his other 2 kids. But lovely family. But he flat out told me, because we were talking about this, and he said, yeah, the law is just totally antiquated. He's like, I mean, we gotta move forward a little bit. But yeah, technically speaking, and again, this is where there's so much confusion about it. What if somebody goes to Colorado and utilizes it there? I mean, do you have to then stop them from a therapeutic medication that you have them on in Texas? What's up?
Do you test for the THC, or do you do? Or is that not in your panel, or?
The stances from the DEA and various other government entities have started actually putting out there that it should be considered to not test for anymore. There are a lot of distinctions on this. It's something that I think people, I mean, you clearly see, I'm scared to even discuss that as well. You know, I don't know a single pain management doctor that enforces that, say, for cancer patients. You know, I mean, you get a patient with cancer, like, you do whatever you want to do. I don't care. And you know, but it's a circumstantial thing. But it's very, very scary. That's the reason that I think it's so important that if doctors were to actually stand up and say, you know what, like, this isn't killing people, and it doesn't really have such adverse effects that we need to be taking other things away from patients and penalizing them, that maybe we'd at least have a little bit more latitude to be able to help some more patients.
Any other questions here?
So what is your idea about our patient population's much older, and we have to worry about renal problems, for example, your example about the NSAIDs making the symptoms go away. A lot of times we don't have that option.
Sure.
So what's your thoughts on that, and maybe like, do you find tramadol being the same as hydrocodone because they're all in the opioid class, or what's your feeling about that?
No, it's a very, very, very good question. We'll get Dr. Rafii also to chime in on this. You know, I think a lot of it comes down to, I hate to use the word placebo effect, but a lot of it does. If I have a patient that wants some sort of pain medicine and I say, you know what, I'm gonna give you a drug that's actually, you're not gonna have to come in every single month to be able to get, and it'll save you, it's a little bit less addictive, it's a safer drug, it's a Schedule 4 instead of a Schedule 2 called tramadol. You know, why don't you try that out? I do that, you know, and that's because there are circumstances where you do need to actually put somebody on something, and you're absolutely right. You know, you see people with liver problems, they can't take acetaminophen. You know, they've got ulcers, you know, renal issues, or, you know, cardiac issues, and they can't take NSAIDs. Absolutely. But the most important thing is making it very clear to patients, if you are going to go that route, whether it's tramadol or if you need something a little bit stronger, go with the Tylenol with codeine before you go with a Schedule 2. But make it very, very clear to them, this stuff is, at the beginning, it's going to be great. And then you're going to develop a tolerance to it. You're going to want to go up, but we are not going to plan on going up. I'm not going to be ramping this up higher and higher. This is a crutch that's there to help you. And I actually always compare opioids to caffeine. I'll tell people, you know, you can drink one Diet Dr. Pepper in the morning for your entire life and get a little bit of pick-me-up from it. You can convert that over to a cup of coffee in the morning, and that'll always work. But if you get to a point where you're drinking like 2 Red Bulls every 4 hours, you're going to be more tired than you were before you ever even drank caffeine. And the same ultimately is true for how the body responds to opioids. So it's just very important to make sure that patients understand that this ain't going to be perfect. But yes, it does have its place. I don't want to pretend like it doesn't. There's also a conflict of interest to say absolutely not to. But yeah, I think always try, if you're going to do something, try one of the weaker things first. Try tramadol first.
What's your thoughts, Dr. Rafii?
Yeah, I'll just say tramadol is great because I think the mu receptor affinity of tramadol compared to morphine is like, it's minuscule essentially. The majority of the benefit of tramadol is from the serotonergic properties of it actually. And so, yeah, if you're gonna pick an opioid for somebody who you really think needs to be on an opioid, tramadol is a good starting point.
Do you still have to do all the drug testing of tramadol and all that?
Technically, yes. Technically, yes, because it's still a schedule.
It's a Schedule 4. It is a controlled substance.
And so, guys, just one question. So what would you suggest for pain control in patients with acute CVA?
Excuse me, I'm sorry?
Acute CVA, acute strokes, pain control.
Oh, gee, well, it would certainly depend on their symptoms.
Yeah, yeah.
So generally speaking, if somebody's got a burning pain,
Yeah.
You know, any kind of burning, tingling, you know, electrical sort of pain.
Gabapentin.
Go with gabapentin or Lyrica. There's sort of, I always tell people, there's sort of 3 branches to the tree for like a neuropathic pain. You got, you know, your anti-seizure medications, gabapentin and Lyrica, generally speaking. You've got certain types of antidepressants, tricyclics and Cymbalta, and then you've got your cannabinoids. And although everybody's very excited about CBD and how that's kind of coming out, you can actually already buy it on Amazon. You can buy it at Austin Compounding Pharmacy. They extract the exact same substance from hemp, and it's over the counter. It's not really. It's the same substance that's going to be this extremely restricted CBD that you're able to get only for seizure patients. But that's. At least make sure to look and evaluate the type of pain. Opioids don't generally control neuropathic pain. But otherwise, I mean, you get a stroke patient, especially an acute stroke patient. I mean, sure, there are circumstances where it may be very reasonable, but just start low. Start very low with opioids. So.
All right. Well, we are running short on time. Could have talked Next up, we're going to just switch out here, and then we're going to have state